Good afternoon, everyone. My name is Annette Johns, and I'm the Associate Director of Policy and Practice with the Newfoundland and Labrador College of Social Workers. We apologize for the brief delay in starting. We had a few technical issues, but those seem to be all resolved there now. So welcome. I have the honor of being the moderator for today's education event, the Virtual Reality Ethical and Practice Considerations for Informing Service Delivery, along with my colleagues Peggy Rauman with the College of Registered Nurses NL and Wanda Squires with the College of Licensed Practical Nurses NL. And this webinar is a collaboration between our colleges. Importantly, I want to note that today's session marks 20 years, that's 2 decades of this educational collaboration between social work and nursing, and we're happy to be celebrating this with you today. We have over 700 healthcare professionals registered for today's event, and it's always so wonderful when we can come together and engage in collaborative learning to enhance our knowledge and skills in providing high quality services. Before we get into the presentations, I do want to go through some housekeeping details. The panel presentation will be approximately 80 minutes. That will be followed by a question and answer period that the moderators will moderate that piece. And during the presentation, we encourage you to type in your questions using the question mark icon at any time, and we'll begin asking them at the end of the presentation. So keep the questions coming in throughout the presentation, and then we'll get to them at the end. And to customize your viewing experience, you can resize and move around any of the elements that you see on your screen. So now on to today's topic. Virtual care, while not a new concept, is increasingly being integrated into the provision of healthcare services and is a topic of conversation amongst healthcare professionals. Our vision for today is to explore virtual care and highlight ethical issues and practice considerations for informing service delivery. Regardless of your area of practice, we hope that you will leave this session with new learning and a spark or an interest to engage in continued conversations and reflection, and how we find that balance between face-to-face and virtual care. We have an excellent panel lined up for this afternoon, and their full bios can be accessed through the bio widget on the platform. However, I just want to briefly introduce them now. So Ashley Din, RN, is the Provincial Program Manager of Virtual Care with the Newfoundland and Labrador Centre for Health Information. Elise Bruce, LLB, is the Corporate Counsel and Director of Professional Conduct with the College of Physicians and Surgeons, Newfoundland and Labrador. Stephanie Mealy, RSW, is the Team Lead with the Bridges Adolescent Mental Health Program with Eastern Health and Vice Chair of NLCSW. And Charlene Brophy is RN and President and CEO of PhoneMed, which administers the 811 line here in Newfoundland and Labrador. So what a truly, truly wonderful panel. And on that note, I'm going to turn things over to Peggy and Wanda to facilitate the panel discussion.
Thank you, Annette. Thank you for the introduction to this event. And as Annette said, our vision for this event was to address some of the ethical and practical considerations when providing virtual care and to provide an opportunity for knowledge exchange, reflection, and learning. So I am very much looking forward to the knowledge that will be provided by our speakers today and for the discussions at the end of the presentation. So to get things started, I will now invite Ashley Din to come forward as our first presenter, and then it's going to be followed by Elise Bruce, and then Wanda Squires will invite the next two presenters. Ashley.
Hi, everyone. So as I mentioned, I'm Ashley Din, the Program Manager for Virtual Care at the Centre for Health Information. So I'll get us started and kind of give an overview of the virtual care program. And I'll give an overview of, post-pandemic, some of our equipment. I'll review some of our projects and initiatives, highlight some benefits and risks, and talk about the virtual care sustainability and our alignment with the Health Accord actions. So I do have a poll I'm just going to put up there now. So have you used virtual care as part of your clinical practice? If so, what do you use? So you can take a moment just to pick one of the options. So it's mostly phone, video conferencing, a mix of video and phone, and I do not use virtual care. All right, so the results are just coming in there now. So we have 27% use mostly phone, 12, or sorry, just under 10% video conferencing, 31% use a mix of both, and about 31% do not use virtual care right now. Actually, once more. Yeah, stay about the same. Okay. So the provincial virtual care team is responsible for the virtual care deployments across the four regional health authorities, but we also support regional initiatives as well. So some non-health authority associations and different private practice groups, we will assist as well with virtual care needs. We have provincial governance for virtual care. So it used to be stated as telehealth, and we've obviously grown from the word telehealth to be more inclusive to the growth within the province and the additional tools. So we use virtual care as our terminology now. So we collaborate with a number of clinical departments, so professional practice groups, the Department of Health and Community Services, medical services, and a variety of other stakeholders to work with their virtual care needs. So our core responsibilities, certainly not limited to the three that are listed there, but we will work to create individual education and training. We'll help with policy development, guidelines, communications, brochures, anything that a clinical department or specific clinicians would need to support their clients using virtual care. We also will provide clinical support, so getting up and running. Once you have your equipment and your processes mapped out, we'll help kind of work through the workflows of using it virtually versus what you might do in person. So a bit of background. So virtual care is a lot of terminology used. So the one that we use within our program is any interaction between a patient and their healthcare provider that use technologies to help them attend appointments and consultations from a distance. So it is certainly a broad definition that we use. And you'll see further when we look at some of the tools that we have, how broad it can be. So, there's many benefits to using virtual care, but a few are listed here. So certainly, as we've seen with the pandemic, access to the technology has been phenomenal during the pandemic, how much it grew. It allows the technology to be provided within a healthcare facility, so you can actually go into a building where you might not have Wi-Fi access or strong access in your home or the right technology to do a video conferencing appointment. So you can come into your local facility or community health building and participate in appointments, or you can have it within your own home using the technology as well. So it certainly increases access across the province. It helps you avoid waiting rooms and clinics where appropriate. So, certainly it helps reduce some wait times as well. And if, there's many, along with COVID, there's a lot of other germs. So if the appointment is appropriate for virtual, it certainly is a great way to access the care. Sorry. Promotes access to health services from a distance where in-person appointments are not possible. So there's our province is certainly very dispersed. So this allows access potentially within a shorter period of time as well. It's just a bit of background. We've certainly seen, we had a lot of usage within our province where I think it's been over 40 years that telehealth has been within our province. And we've seen a huge increase since the pandemic. We already were, pretty high usage as compared to other provinces, but certainly has expanded significantly since. We've expanded into areas with urgent and emergency care, whereas mostly urgent and emergency was only used within the Lab-Grenville region. So we've seen that now expand across all four regions. There's virtual care is being used to increase access to primary health care. So we see that expanding now with the collaborative team clinics and other fast track access to primary health care. and deployment of more facility and home base. So we've expanded our use of facility base along with our home base. And we've also increased the amount of peripheral devices. So I'll go a little further into those in just a few minutes. So post-pandemic, this was the height of our deployment. So we certainly don't have all these accounts still active, and we wouldn't expect them all to be active to date. But during the height of the pandemic, we had over 4,500 virtual care accounts deployed to clinicians across the province. So this was both RHA employees and private clinics. We're expanding both home-based and facility-based services. And it was an increase in both video and phone. So there was certainly a high increase in phone, especially early in the pandemic, but video did increase over time as providers got the right access to the right equipment as we adjusted to the lockdowns at the time. So there increased access to mobile health services. And then there's also been the shift to collaborative teams. So using multiple clinical backgrounds to support clients, using the mixed model approach, and also the mix of in-person and virtual care. So this is just a quick overview of our current solutions. So right now in the province, we do have a hybrid infrastructure. And we have a number of peripheral devices. So within the province right now, most people would probably be familiar with Zoom for Healthcare or Cisco Jabber. We are in the process of moving forward with WebEx, which will allow clinicians to not have multiple solutions. They'll be able to use one solution for all of their needs. And that'll help us balance in-person, or the in-home, and facility-based as well. So our most used peripheral devices is the e-stethoscope. So we have two types of e-stethoscopes that we use. And you can hear the live auscultation through the app with this stethoscope that we use today. And we also use a HD examination camera. And with that comes like a general viewing lens, there's a dermoscope lens, and an otoscope lens. And the examination camera is probably our most used peripheral device. Especially now that we've expanded to urgent and emergency care. So as mentioned, Zoom for Healthcare is still one of our technologies, but there's other solutions that you're probably familiar with. So with TELUS Med Access, they have virtual visits, eMental Health and Addiction. So there's a number of tools and virtual video conferencing solutions within their program. Remote Patient Monitoring has a video conferencing solution with their current vendor. There's also secure messaging and then telephone. And then just kind of a little bit on the privacy and security. So with the two solutions that we do have deployed and moving forward with WebEx, all of our solutions are end-to-end encrypted. So there is that secure measure, and moving forward with WebEx, it really gives us that extra level of security to protect both the clients, the regional health authorities, and the providers. So as you can see on the screen, I know it's probably very small, but in the larger section over here, you can see a clinical cart. So that would be one of our, actually, I'll switch to the next screen, get it bigger there. So this is just a typical setup. So the provider can use just a laptop. We do recommend a good webcam. Sometimes the internal webcam of the laptop is suitable for the appointment. We do test those out. They can use an iPad or other tablet. And then on the patient side, if it's facility-based, they would use a clinical cart. There could be a wall-mounted unit, or it could be used with just an iPad, depending on the requirements of the clinical group. So as you can see in the top right corner there, that is the examination camera, and below that is one of our types of stethoscopes, e-stethoscopes. So some current initiatives that we have. So right now, the virtual pre-admission clinic that went live just in January. They've already had a number of clinic days with this, and we're already planning to expand to other sites across the province. So this is allowing patients to have their pre-admission done virtually to potentially avoid unnecessary travel, or limit the amount of time they do have to travel before coming to St. John's for surgery, for example. For the virtual ER, we have 12 sites that are live over the past 18 months. They're not all live at once, but all the sites have been trained, are equipped to go live at any time. We have NICU and PICU that have both gone live within the last year. And this is to allow the neonatologists for the NICU project to lay eyes on the baby and help prepare them for transport, stabilize, or potentially support the physician on the other end to prevent an unnecessary transfer to the NICU. Other areas, dermatology, cancer care, cardiology, nephrology, there's so many more. And certainly anybody who's on this call can probably, there's probably virtual care used within your area. So this is just a map. I think we might be missing a couple dots, but most of it is there. The stars do represent our virtual ERs, and the rest of it is color coded for the regions where there is sites that have in-person video conferencing. So just switch over to Labrador so you can see that one as well. There you go. And the next one, so balancing the risks and benefits. So there's always a balance, and I know some of the other presenters are going to cover this more in depth, but would the service be offered virtually, or sorry, would the service be accessible if not offered virtually? So it is balancing that level of risk. And there's always considerations for virtual care. So we will work with all the clinical, any of the clinical groups to work on, selecting the right patient, preparation. The team will make, process maps and documentation workflows so that, all the right steps are there to support the clinicians when using virtual care. So we support, as mentioned before, supporting policies, guidelines, and procedures. So if there is a specific group that we're working with that needs, our standard guidelines for using the technology are not suitable, such as the NICU project, we would have tweaked those to do up specific workflows for them so that it is a well-guided process and they have all of, we're helping mitigate any risks as well to make sure they have everything they need to be successful. And then suggested order of appointment. So just, our basic, make sure names of all parties are listed at the session, your positive patient identification. You ensure the patient understands the consent terms of the appointment, and it varies by different clinical groups, and then you would proceed with the appointment. And certainly we would modify the suggested order based on the clinical group. So the next slide is the next two slides actually is the virtual care usage. So this are all clinicians that are signed up with either Cisco, Jabber, or Zoom for Healthcare. So if you are using your own Zoom technology, or some people use, they might have their own software within their department or their private clinics. They're certainly not represented here, but these are the ones within our provincial system from the licenses that we have deployed. So we did it over a 3-year period, and it might be hard to see, but there are trends on the right side to show that, the trends aren't necessarily dropping, since COVID. Some of the areas have actually picked up and are increasing their numbers as they go. Switch over to the next one so you can see some more clinical groups there as well. And if anybody wants to get any further numbers for their specific area, they can certainly follow up with me and I can help with that. So for sustainability planning, we are still working at our mixed model approach as we're able to support the regions. It's certainly a mixed model of accessing clinicians that are on site while getting additional support virtually. And we're strengthening clinical workflows. So we're helping, meeting with teams to help balance in-person and virtual services and adjusting to the new normal. Because virtual services have certainly expanded, and there is, clients do want to have virtual. They want the option as well, right? So we're increasing access to clinical teams. So we're allowing more helping support more collaboration, and increasing access, in a more timely manner. So provincial integration and interoperability with virtual care as we move forward with a number of the initiatives that are happening across the province, we're always looking at integration and interoperability for virtual care to incorporate it into the documentation systems that exist today, reviewing other video conferencing solutions that might exist. So how can we help, when you're scheduling a virtual care appointment, could it be documented within and captured and scheduled within your current documentation system? So we are always working with the various other stakeholders across the province to work on that. And then the provincial health cord blueprint, there's a number of action items within there that are specific to virtual care. So I'm not gonna go through all of those, but this is just a few from the health accord that you can see here on the screen. So we'll certainly be, working towards those over the next few years to help achieve the action items within the health accord. The next slide is just a snapshot of our virtual care website. So the team has done a great job of updating it over the last few months, and we are constantly building it out and adding more features. So it's a great place to go to get more information. Our training materials are there. There's information for providers and staff that support providers scheduling virtual care appointments. So I have one more polling question I am going to pop up there. So after hearing, I know it was a quick kind of summary of virtual care, but do you think you will continue, or do you think you would start to use virtual care as part of your clinical practice? So I will just pop up the poll here now. So it's yes, mostly phone, yes, using video conferencing, yes, a mix of video and phone, and no, virtual care is not suitable. I'll just give everybody a minute there. All right, so about 25% said mostly phone, 6% mostly video conferencing, 56% said a mix, and 10% said not suitable, almost 11%. Just refresh it, see if it adjusts. Yeah, so it's certainly going up there now. So just to conclude my area, so as our province moves ahead with the reconfiguration of healthcare, these virtual emergency rooms are envisioned as an element in reimagining the health system with the possibility of integration into ambulance services, provides access to emergency rooms and expertise in remote settings through rich audiovisual technology. So this is just a snippet of one area that we're looking to expand in, and this is with our virtual emergency room. So it's great to see. And just a quick snap of our team. I won't leave that up there very long, but if you guys want to follow up, I certainly can guide you to the right person in your region. And I will hand it back to you, Peggy.
Thank you, Ashley. I always enjoy watching your presentations because you give such a holistic view of what it looks like with virtual care across our province. So thank you for that. And now I'm going to introduce our next speaker. So Elise, it's over to you.
Thanks, Peggy. So good afternoon. I'm going to speak with you this afternoon about managing risks and unintended consequences of providing virtual care. So at the start of the pandemic, many of you likely made a quick switch to practicing virtually because there was no other options. And I would say, most healthcare professionals did their best to do what they could in those circumstances, recognizing that the switch to virtual care was mostly out of their control. But now in 2023, we're in a situation where in most circumstances, virtual care is being provided by choice. Patients and their practitioners are electing to provide virtual care over in-person care for different reasons. And we're starting to recognize that virtual care can be a benefit to patients. And we've seen this especially in Newfoundland and Labrador in underserviced areas of the province, where there's limited access to healthcare practitioners. It can also be of a benefit to patients who have difficulty accessing a clinic due to disability or lack of transportation. It can be quite costly for some patients to travel to access in-person care. And virtual care can open up some opportunities for individuals who have familial responsibilities such as childcare or elder care, which impact on their ability to access healthcare services by leaving their homes. And so today I'm just going to speak briefly from my background, which is in professional regulation of physicians. But it's clear to me that we're continuing to learn about the strengths and also the limitations of virtual care. And as a result, the relation of healthcare professionals who are practicing virtual care is quickly evolving. And I've put together a list of questions that you may want to consider when you are making the decision to offer virtual care in your practice. And I should make it clear that this is not legal advice, but it is a list of questions that you may wish to reflect on in your practice. And so before I get into the questions, I think it's important to remember that regulated health professionals are generally held to the same standards of legal, ethical, competent, and professional care when providing virtual care and in-person care. So you are expected to meet the same type of standards if you're providing virtual care. It's not a lower standard. So I've put together some questions, and the first question I think is always important to ask is virtual care in the patient's best interest? And so in deciding whether it's in the patient's best interest, it's important to reflect on whether it's effective for this patient. So is virtual care suitable for the needs that this patient is seeking? The care that they require, is virtual care effective? And can you provide that type of care through a virtual medium, or is an in-person medium more appropriate? And I think you should also consider whether the care can be provided in a timely manner. So will there be any delays in the care that you provide because you're not seeing them in person? So sometimes what happens is you'll start a virtual visit and then realize you need to switch to an in-person visit and then have to book an in-person visit. So consider at the outset, is it the type of that should start as an in-person visit or a virtual visit? It's important to reflect on whether you can effectively communicate with this patient virtually. So I would consider, are there any language barriers or cultural barriers which would better be supported through in-person care? And depending on the circumstances, you may need to build a certain amount of rapport and express empathy towards that patient. So are you dealing with an emotionally difficult circumstance where you feel that you can provide the care virtually, or would it be best to have that conversation in person? Do you have a plan for managing adverse events? So do you have supports on the ground where the patient is located to manage an adverse event? Is the patient aware of what to do if there is an adverse event? And do they understand what steps to take in those circumstances? And if during the encounter you reach the opinion that the patient requires in-person care, do you have a plan for arranging it? Do you know how best to direct that patient to obtain necessary in-person care? And then I would go on to consider questions about privacy, confidentiality, and technical requirements. So depending on the type of practice that you have, are you able to confirm the patient's ID? Is it the person who you think you are speaking with? And can you ensure confidentiality? So again, depending on the circumstances, you may wish to consider asking the patient, is there anyone else in the room with you? If there is another person with them, you might want to consider how that might impact on the care that you are going to provide to that patient. Would that patient still feel comfortable answering questions that you might need to pose as part of the healthcare care that's being provided? And always be alert to the fact that the patient or another person in the room could be recording the conversation. And as you can imagine, this is a lot easier to do virtually than it is in person. So in the back of your mind, when you're having a virtual encounter with a patient, I would be aware of the fact that they could be recording it. And then you'll want to consider if the platform is secure. So are you using a platform that's been tested for healthcare setting, or is it a platform that's used more for social settings? And do you have the necessary technology? So do you have equipment that works well and is reliable? And if you or your patient loses the connection, do you have a plan of how you can connect in another way? And then I would go on to consider documentation. So if, as part of your practice, you would normally review a patient's medical records in advance of a visit, or do you have the ability to access those records that you need before this visit if you're going to proceed virtually? And after the visit or during, depending on how you document, are you able to document it like it is an in-person visit? And are you able to record the visit and then integrate that back into the patient's chart in the same way that you would if it was an in-person visit? So making sure that you have that continuity of the record is really important. And so I would also go on to consider what are the limitations. And in some cases, there are going to be limitations on providing virtual care. And you may still, depending on the patient's circumstances, find yourself in a situation where you decide to proceed with virtual care, even though you know there are limitations of proceeding in this way. Because of whatever reason, this still feels like the right thing to do for this patient. So in those circumstances, I would say it's really important to identify and explain what these limitations are and make sure that the patient understands any risk that they're taking on in proceeding virtually versus trying to make arrangements to see a healthcare practitioner in person. And once you've explained this to them, I would suggest that you want to consider whether you are able to get their consent to proceed so that they understand what's happening and that they are okay with moving forward in that way. And always important, all of you are regulated health professionals, I understand. So you likely the regulatory body that has provided you with a license has a policy relating to virtual care. So important to have you reviewed that policy. Is your practice compliant with that policy? Are there any concerns there? And this one is a bit complicated at the moment. If you're engaging in cross-border practice, so if you're providing care to a patient in another province or another country, it's not very clear at the moment in some circumstances, which jurisdiction may have authority over you. So you may want to consider, are you practicing in Newfoundland when you're providing care to that patient? And if not, might you need a license to practice in the location where the patient is located? So always important for cross-border practice. And as I said at the beginning, the regulation of the practice of virtual care is evolving really quickly. So I think it's always important to keep apprised of best practices. I think it might be easy to get behind because of how fast things are moving. And I hope this presentation offered you some questions that you can reflect on in your own practice of providing virtual care.
Thank you very much, Elise. You did give us a lot to reflect on, and there's some very interesting questions that I think are very important when thinking about providing care virtually. So now I'm going to hand the moderator over to Wanda Squires.
Thank you, Peggy, for that. So now I would like to invite Stephanie Mealy, the registered social worker, who's going to speak to us today on various ways that they offer virtual care.
Thank you so much. Good afternoon, folks. So I'm just going to share with you just sort of some experiences, in my daily work as a social worker with Eastern Health, in my particular position, but also try to generalize it a little bit for some others. So I work with the Bridges Adolescent Mental Health Program. So just super quick, we are a mental health service for teens between the ages of 13 and 18. We're a focused treatment program. We provide individual and group therapy, as well as family support as well. We try to offer an integrated range of services. And we've always kind of been rooted in technology, even way back to 10 years or so ago when we started to think about, how could we reach out to teens, and eventually developed Bridge the Gap many years ago. So even way back all those years ago, we were sort of knowing that technology was a very important part of our work, especially with the adolescent population. So how do we offer services? Well, up until 2020, we were 100% an in-person program. And then, of course, in 2020, the whole world changed. So we then started to kind of pivot and figure out how are we going to manage our services to still keep that continuation going. We didn't have a lapse, luckily. We were super lucky. We started to do phone, and of course, that sort of evolved into virtual sessions, which then evolved to virtual groups, and then eventually, over time, still having mixtures of in-office sessions as well. So, virtual care in mental health. Just as I've mentioned earlier, essentially for our program at least, it is something that really has evolved since COVID. Prior to that, I think the occasional clinician might have had some telehealth experience with clients of different parts, of the region, but we weren't really sure. Not many of us were doing it at that point in time. And that's certainly evolved, over the last couple of years. So in terms of that, the options, they vary, and they really will vary depending on the need and the capacity, of a client. So their needs and whatnot get evaluated a little bit prior to us from our central intake folks, but then we're always kind of, reviewing that and doing that assessment capacity piece to see, if we think that virtual care would be an option for clients. So whether that's from us or for parents, from the client themselves, we're kind of constantly reviewing that capacity piece to see if we might need to change. Sometimes folks feel comfortable starting off with phone, and then they feel like they might want to kind of, move it up. So we're always kind of monitoring that regularly. Um, we have been primarily using the Zoom Secure Health platform, or Zoom Health. I know that there's lots of other options that my colleagues have talked about today, but primarily here we've been using Zoom Health. And like I've mentioned, for years, historically, telehealth has certainly been an option that many of us have been using with our clients. We've often had teens from all around the province join in particular therapy groups, DBT, for example, at the Janeway. But it's been something that has always been going on, but has evolved even more so since COVID. In terms of the promotion of virtual options, I know that that's definitely something that has been happening a lot over the last number of years, especially since 2020, of course. And it's really something that I think has just even evolved even more so. So, from therapy assist online programs, self directed programs, to things that are a little bit more directive, we've constantly been kind of going back and forth, and where appropriate and where applicable, providing and at least offering the services of virtual care to clients and giving them that kind of hybrid model is something that I think a lot of people have been really sort of liking. So, in terms of social work and virtual care, there are lots of things that we need to kind of keep in mind, when we're reflecting on practice and our clients and whatnot. Some of us use electronic practice. And so, if that's the case, we're certainly responsible in terms of our code of ethics, our standards of practice, and whatnot to adhere to those values. And that could mean sometimes having to consult with those standards of practice, codes of ethics, and even having like regular ongoing social work consultation. Because for many of us, this was something very, very new. So we could look to our college to look and see what resources they have to provide to us, which has been really helpful over the last number of years. There are ever-changing documents that seem to be produced that can really kind of, help us and give us that added support. So always having that consultation piece we find is super helpful for our clients. In terms of virtual care, I mean, we've always sort of talked about over the last few years, how are we doing with it? How can we improve it? Can we change it? That type of thing. And in terms of the gaps that it's been addressing, they've just been really phenomenal. From a program who didn't really use it before, we've certainly come, I think, full circle to really see the value. So just in terms of basic things like accessibility, for many families and teens, there are transportation issues, obstacles. So those things can be, essentially eliminated, and it can just be more accessible in general to provide virtual care. It's certainly time friendly. I know that many parents struggle to take time off work, and children are coming out of school to get here, and and parking and waiting rooms and all that kind of stuff, like my colleagues have talked about earlier today. So it certainly can be a very time friendly option. And then kind of with that is that flexibility piece. So, sometimes we can have, pop on for, just a couple of minutes, whether it's a coworker, a colleague, a doctor, a parent, somebody like that, if we just need something super quick. So it's really given us a lot of flexibility where we didn't really have that before. And clients are telling us that it's less disruptive. So again, it's that time piece, right? And we all know that time is valuable these days. So it can be less disruptive in their lives if they can have a session, at home or something like that. And as I kind of mentioned earlier, it really kind of extends that continuum of care because we now have that option to case consult, quite quickly. There are more options open to us as staff, and even just simple things like group work, where we would have to limit the number of teens who could attend in-person groups. We no longer have that sort of cap to kind of think about. So it really kind of just broadens and expands like the services that we can offer. And in professional growth, I mean, it's something that whether it's a training opportunity, we've been able to do trainings all around the world, as well as that consultation piece. So just from a social work lens, but also like for the services that we're providing to the public, it just gives us that opportunity, to learn and grow, yeah, much easier and in a less costly way than the traditional travel and training from before. Um, Virtual care and informed consent, it's a super important topic. Informed consent, it's something that we constantly talk a lot about sort of in our area in social work. That just that whole notion of informing clients about the technologies that are being used in delivering of social work services, including the risks and including the opportunities. So it's really about like going through that kind of voluntary agreement with our clients to make sure that they're aware of the risks and the information, the benefits and all those things that would be associated with it. So here at the Bridges program, we have developed an orientation package since COVID has started. And so we're trying to kind of, cover off the different risks and the benefits so that the client is very much aware of those things up front. And that can help them when they're determining, their choice for how they would like services delivered. So we have organization standards, of course, from Eastern Health, and we're reviewing these things, that we do send them virtually before we even meet them. So we give the client and the parents the opportunity to go through that, but then of course we're going through it with them ourselves. So making sure that that teens know things that they have to be ideally by themselves and in a private and a confidential place. So we can see them to know that they're there and all those kinds of things. So we'll go over all of the virtual care kind of consent forms and really focus on that informed consent piece to make sure that those expectations are super clear and that they would treat it no differently than if they were, in our office. So little things like making sure the room is well lit and that, you're sitting up and, screens are on, volume and eye contact and all those kinds of things. So we're constantly sort of reviewing those things with clients, trying to continue developing information to make sure that everybody, has that knowledge and understanding before they make their decisions to choose virtual care. And just in terms as social work, in terms of our professional practice standards, it's certainly something that is always in the back of our mind. And when we're talking about these things, like one of my coworkers mentioned earlier, we're trying to think ahead and think like, if something were to happen, what are the emergency services like and what are the options and how it would really be no different than if you were in our offices. But again, making sure that people are aware of those things. And for all of the strengths, of course, there are some limits. There are definitely, oops, sorry, my slides changed. Okay, so there are some limits of virtual care as well. Like just then, a technology issue. It's something that we talk about upfront with our clients, and so for that reason, we always have to have an alternate plan in place. So if something should go awry or whatnot, making sure that we have a phone number, an email address, something like that. And making sure that we have all those connections as well virtually for other emergency services and making sure that clients have that as secure as our platforms are, and I know that Zoom Health is, a very secure site, and we can once we're in that, we can even lock the room to keep it more secure. So we know that that piece is there, but we do talk about, there is a potential breach. Um, access to technology. Sometimes, depending on where people are, they may not have access to that. I know that lots of us think that most teenagers do, but not everybody does, of course. So that could possibly be a limitation. That whole notion of virtual care, we may not be able to offer it to some for that reason. Some people don't have a comfort for the use, depending on the age range, and just in general. Lots of people just don't feel comfortable with virtual care and technology in general. So we always have to factor that in and not just assume that a person is going to be okay with it or have access to it. Uh, Sometimes there can be like a lack of visual access. So, for the most part, we're seeing someone's head or maybe like the top part of their body, that kind of thing. But we can't really see, anything else sometimes. So, that can be a limitation, of course, as well. And when we're always trying to, maintain people's privacy and their confidentiality, that can sometimes be like a little bit of a thing. And sometimes we get into some struggles with that, with our screens being on and off as well, for various reasons. Sometimes people aren't, quite comfortable necessarily having their screen on. So we kind of, talk that through with a person, with a client, to see if we may be able to come to some kind of, mutual understanding and compromise. Certain treatment issues, for various reasons, whether it's just for safety, whether it's high risk. Sometimes, we've kind of consulted here amongst our team that, there may be some treatment issues that we may not feel comfortable, treating virtually. And we may feel that it may be just for safety reasons, for client safety, it may be best to have the person in the office. So, there may be some treatment issues where this isn't appropriate. And just in general, like risk situations, again, like it's something that we can, always try to kind of prepare for, if need be. So we always need to try to take those things in mind and learn from our experiences so far. So some of these I've mentioned a little bit earlier, but there are many, many strengths of virtual care. Of course, the COVID barriers is a big piece. As an Eastern Health facility, we still are following the mask mandate, for example. So some teens and families are not comfortable wearing their masks here as soon as they enter the building until they leave the building. Even just little things like passing things back and forth. In the very early stages of COVID, it wasn't even really recommended to pass back handouts and things like that, or if people were signing things. So it can really eliminate so many of the COVID barriers. And some people say that, if it's still personal, even though it's over the video. But again, with the mask on, they actually feel like there's more of a connection there. So in terms of that relationship building piece, lots of teens have shared with us that they actually prefer this method to in person, which is kind of interesting. So again, that family-friendly nature that I kind of talked about earlier, the fact that it's less time off work and all those kinds of things for families and less uprooting them to get here. So there can be many strengths viewed in that sense. I definitely think it is teen friendly because, it's about meeting the teen where they are. And just in terms of like, the stigma that still exists out there, many teens are not comfortable coming into a mental health facility to a program like this for an appointment. Again, and if you think about, again, transportation and geography, all that stuff as well, but it can just be a more teen friendly environment where they're kind of like in their comfort zone, so to speak. So the sharing of resources pieces is also something that we didn't really realize would be a strength, but really is. And so, like I mentioned, we can easily email, and send information to clients, links and websites and handouts and things that we've prepared, documents and templates, much easier this way than it would be to print everything off and to give it to people here. Sometimes we would send things in the mail, that kind of thing. And although we can still do that, it's definitely something that can be, very, very helpful. And I think it's also a very, really cool experience actually to see teens in their own environment. I find that for that relationship building part and just for everything else, we're able to see teens where they are. Most times they might be in their bedroom, for example. So you can get to see things that are important to them. And from a therapeutic perspective, if we're doing grief work and we can see, a blanket that Nan made you, or if we can see their pet, as their therapy animal, we get to see those really cool mementos in the room, and it really just brings that relationship building and even just the therapeutic work to a whole new level. So it's been a pretty cool thing that's would definitely be a strength of virtual care. And it does certainly help to remove lots of barriers as well. Like I mentioned, even the stigma, but then the physical barriers. Sometimes, parking, appointments can be a little bit quicker sometimes if we're doing them over Zoom or the telephone or something like that. So it's really just removing barriers from a parental perspective as well. Um, and of course, the option of choice. Sometimes clients will choose a virtual session, but then we try to offer that hybrid model to folks. So if they're really feeling for whatever reason like they would really just prefer to come in, of course they can. But again, they get that choice. So it's really just kind of putting it back to them. And again, that notion of having that quick check-in, whether it's with a client, a coworker, a family member, a professional, a colleague, we can sort of have those quick check-ins now, whereas it would have been much more difficult to sort of coordinate that and everybody's schedules and whatnot prior to COVID, essentially. In terms of provincial stuff, what we call interjurisdictional consideration. So when you're thinking about that, this is more of kind of like a general statement, for other social workers out there. For me personally, in my job, I'm working here locally, but certainly if social workers are, practicing virtually and they may be practicing in other jurisdictions. So whether they're providing counseling to services to people in other jurisdictions or they're providing local, but then the client moves or travels or whatnot, it's we definitely have a responsibility to be aware of those issues. So where the person is residing, we kind of need to look into that stuff. We need to look into connecting with the, I guess, the local regulatory body, where the client is residing or where they're located, and really clearly sort of explain how they will be providing services to them, the different requirements, maybe registration requirements are different. So when we're kind of factoring in that service delivery, it's really important to ensure that we're following those regulatory requirements, again, where the client is. And it also might be something that just in terms of like emergency services and things like that, we would want to be aware if we're working with a client, elsewhere. So checking in with your local regulatory body, again, that informed consent piece is huge when you're looking at crossing over into different, provinces or countries. Really clearly explaining to the client like what you can and what you're offering, and again, always outlining what the expectations are and if there are any limits to the service options that you're able to provide virtually. Again, taking some time to kind of check out like the local referral services. So if you need to refer a client afterwards or even during your work together, what some of those services might be in that area, especially local emergency services. Again, if things are change and become more high risk, really being in tune to know what those options are so that you can clearly give them to the client or make sure that they're sort of arranged if need be. And again, if working privately and you're providing this kind of practice, certainly making sure that you have that like professional liability insurance piece. That's certainly an added piece that's really important for us to consider. In terms of just sort of like general considerations, for practice as a social worker in this area, I mean, we have certainly seen in our program how our program has really evolved as a result of virtual care. In the very beginning, we were very unsure and skeptical. So it just proves that that whole notion of being open is so vital. Being creative, I think we've all had to pivot and be very creative in terms of how we can still continue to provide services to our clients. And I think we've certainly been that. So always keeping that in mind of how we can be creative when we're providing virtual care. Being mindful of our standards of practice, again, our codes and our ethical guidelines, no matter what our profession. I think we're constantly seeking feedback from our clients. It seems to be, I mean, that sort of is always the case, but certainly since we've been providing virtual care and the hybrid model, really getting that feedback regularly from clients, because it certainly does impact our work and we've often made changes and improvements. We've modified things as a result of that feedback. So certainly making sure that, we're always sort of doing that because again, this is all connected. It's all about that quality improvement piece. And at the end of the day, we want to be providing a quality service to everybody. And again, that relationship building piece, which is so important to us in our profession, we really wondered, how will virtual care impact on this? And and I think as a program, we've sort of said, you know what, it's still there and it's still very strong. And some people would even argue that it's even better, for those reasons of being able to see teens in their environment and all those kinds of things. So just some basic considerations to kind of think about. And I just wanted to thank everybody for their time today.
Thank you so much, Stephanie, for the information that you've shared on the availability of virtual services, certainly from a social work perspective. I know several people who have greatly used this service throughout the pandemic, the virtual sessions, and it has tremendously helped them a fair bit. So I thank all the social workers out there and the counselors and everyone else who has or who have participated virtually with clients throughout the province of Newfoundland Labrador. So that's great. So moving right along, I would now like to welcome Charlene Brophy, who is a registered nurse, and Charlene is going to speak on phone med, virtual care, and telehealth. So welcome.
Thanks so much. I appreciate it. And hello to everybody. I'm delighted to be able to have an opportunity to tell you a little bit about our organization today. I think prior to the pandemic, very few people knew who PhoneMed were, and very few people knew who 811 even was. And since the pandemic, it's like everybody knows who PhoneMed is and everybody knows what 811 is. And we even joke these days that sometimes we even get calls from individuals who are looking for a Maytag repairman, but that's not really a joke when I tell you that. We have had those calls as well. So great to be here today and tell you a little bit about us. So in Newfoundland today, even though we're known to be running the 811 service in the province today, we've been around for about 25 years here now. And even though we started the business here in Newfoundland in the early days up until 2009, all of our business was on the U.S. side of the operation. So it's only since 2009 that we moved into Canadian operations, or Canadian service operations, I should say. So we are a company that provides both telehealth services as well as telehealth technology as well. So under the services umbrella, we provide nurse triage services, excuse me, similar to what we're providing today on the 811 line. People calling with various different symptoms, and we're simply assessing those symptoms and so on, and providing care advice at the end. We've also, since the pandemic started here in Newfoundland especially, and we have been doing it for several years, on the U.S. side, provided virtual care escalation services. And, so basically escalating calls to nurse practitioners for diagnosis, treatment, and so on and so forth. We also run various different remote patient biometric monitoring programs. So under that umbrella, we've got patients right throughout North America, predominantly throughout the U.S., who are on various telehealth devices. So it could be a patient on an O2 sat machine. It could be a diabetic using a blood glucose monitor, and various different devices, blood pressure cuffs, and so on to manage heart failure patients. They get home, they check their readings, especially post-discharge from the hospital. They check their readings at home. If they're outside preset parameters, we receive an alert. That alert will come into one of our intake agents throughout Newfoundland and Labrador. And prior to the pandemic, it would have been in Corner Brook or St. Anthony or Stephenville. But since the pandemic, all of our agents are located remotely throughout the province. And then that agent will take that alert and then farm it out to a nurse located in whatever state the patient is located in. And then that nurse manages the patient call from there and can connect with physicians if need be, adjust therapy, and so on, with the goal of keeping the patients out of hospital and managing their care at home as best they can. We also run various behavioral health programs. So under that umbrella of behavioral health programs, some of it is a managed care programs where we're doing outreach calls to individuals who have been diagnosed with various mental health disorders and so on, or managing risk assessments for individuals who are experiencing a crisis situation or just anxiety in general, who will reach out to us. And we've got risk assessment guidelines that we use to monitor individuals and complete a risk assessment and come up with a plan for care as well. So we've got, especially popular under the behavioral health programs on our U.S. side is the university population. We've got about 120 universities that use our services in the U.S. to manage their student health populations, many of them under behavioral health programs as well. So today we provide outreach to about 40 million individuals, predominantly throughout North America, but we've also got multiple different international clients as well. So for our technology offerings, We basically go into any health contact center in any country and allow them use of our technology, and they run their own clinical programs. So we've been using that technology to manage client care in multiple different countries for about 10, 12 years right now. So we started in Bangladesh and Manila. We got multiple clients throughout the Caribbean, several clients in the US, of course, and most recently moved into Asia and have got a significant population in Singapore today as well. So, and that's really growing our international breadth of our technology clients as well. So on a monthly basis, we manage well in excess of 100,000 encounters, not all here in Newfoundland, obviously, but throughout our different provinces and throughout the US, it's roughly around 120,000 encounters we manage every single month for patients, whether that's triage or biometric monitoring, responses and so on. All of our executive team are here in Newfoundland, even though it's an international operation. All of the executive team and the bulk of the clinical leadership, certainly for all of the Canadian operations, are here. We've got hundreds of employees, and in Newfoundland, Labrador alone today, I would guess roughly around 200 plus employees just in the province here today as well. So to kind of bring it home and tell you a little bit about Newfoundland. So of course, the 811 line, it's, symptomatic based calls, somebody calling in with, various different symptoms. We complete health triage or looking for health information on various different disease processes or medications or whatever the case may be. And as I referenced already, during the pandemic, very quickly, we rolled out with a nurse practitioner program as well. So in Newfoundland and Labrador, we've got 30 odd probably 33, 34 nurse practitioners that work with us in various different point positions. And under that umbrella of nurse practitioner escalation, we can either escalate calls from 811 for somebody that needs diagnosis and treatment and so on, strep throat or various different types of urinary tract infections that are recurrent and so on. Or we get a lot of calls from individuals who need prescription refills and simply cannot, either don't have a family physician or are unable to access an appointment and so on. So that's been a very popular program. We manage several thousand nurse practitioner calls every month right here in Newfoundland, Labrador as well. We also run the provincial mental health crisis line. So deal with situations from individuals who are experiencing various mental either health crises or situations, lots of calls related to anxiety and depression and so on. And our specialized training nurses will complete mental health crisis assessments and come up with a plan for care and so on. And then we also in Newfoundland run various different programs, one being what's called a Left Without Being Seen program. So this is for individuals who will walk into emergency department, triage at a certain level, CTAS 2 or 3, and then leave prior to being seen. Then we will reach out to these individuals and check on the status of them and if necessary, complete an assessment and determine a plan for care and a path forward and so on. And many people still are unaware, we also got a dietitian available on our line as well, who can provide dietetic advice as need be and so on. And lots of times we will refer calls from the 811 line from callers looking for information, especially newly diagnosed diabetics and so on. So having that dietitian available to, to guide some of those nutrition questions has been particularly helpful as well. And I've got a little bit of a spinning here. Here we go. So I know a lot of this you've heard already, the pros and cons of managing virtual care, what we can do virtually, what we can't do virtually, and so on. And it's really and truly, as you've heard already, all about managing the risks. Identifying what the risks are and managing the risks to the best of your ability. Ultimately, the greatest pro of virtual care is that access to care from individuals located anywhere at any time, being able to reach out and access healthcare, whereas otherwise may not have any access to care, is of course, no doubt about it, the best pro that we could ever have for managing, for providing virtual care. And then especially over the last 2 years in particular, when we look at exposure to communicable diseases, now more than ever, it's so important to reduce exposure. And it was so interesting early on in the pandemic, where all we heard about is too many people in the emergency room, we can't manage the volume and so on, to all of a sudden, where is everybody? And nobody is going to the emergency room because everybody was so afraid of the exposure and so on. And that became a whole other level of concern altogether. But, the virtual care piece really does limit the exposure and providing the access to care helps an individual determine whether they require hands-on care or whether it really and truly can be managed at home and so on. So, the goal, of course, is to reduce the strain on the acute care system by redirecting patients away from the emergency care system when it's appropriate. And of course, we all know there's challenges in doing that, no doubt about it, with limited resources and availability of hands-on care. But, certainly our goal is to support the public system and help reduce any of the demand on the system as much as we can to our ability. The risks are, you've already heard about as well. The technology, when the technology works, is great. When the technology doesn't work, that's not quite so great. So there's always limitations there. And in Newfoundland and Labrador alone, we still have so many areas without the high-speed internet availability and so on. So for many of the encounters that we manage here in Newfoundland every month, many of them are over the telephone still, because there still is a lot of areas in the province without access to the internet and so on. But we can always provide access over the phone. And again, even for the virtual care appointments where we're using video assessments, it's great as long as there's a good internet connection. But we always need to be prepared, in the middle of the call to be able to turn back to the telephony encounter versus video if need be and so on. And then you heard already about some of the assessments which we can manage virtually and some which we can't. There are some conditions that no matter how great the nurse on the other end of the line is, you need hands-on care, as everybody knows. All situations cannot be managed with virtual care. You take somebody presenting with an acute abdomen, for example. Trying to manage that over the phone is very limited, or with chest pain or, difficulty breathing and so on. And so there are some limitations in what we can do. And again, it's back to managing the risk to the best of our ability and providing, first aid advice or immediate care to be able to manage the patient situation as best we can until they can actually access hands-on care and so on. So it's all about a coordinated effort, managing the risk for what can be managed virtually, and ensuring that we have the pathway forward for individuals that actually require hands-on care when need be and so on. And then, as everyone can imagine, the communication, which you've heard already, is so important, and how we communicate with individuals and so on. And, even from the communication perspective with different languages and so on. So, we try in our recruitment efforts to hire, especially on the Canadian side, French language nurses or bilingual nurses and so on. That's been particularly challenging in Newfoundland and Labrador, as you can well imagine. But that's important to us to make sure that we hire as much as we can bilingual agents to be able to manage the calls. And then when we don't have a bilingual nurse available to manage a patient call, that we always have an interpreter service available that we can use, so that there's never a time when a patient who's in need cannot be managed. So talking a little bit about in Newfoundland, and I think anybody that listens to Open Line in particular, you'll hear, oh God, 811 refers everybody to the emergency department. And even though when you're in the front line and you're at the emergency department, I get that sometimes it can feel that way, because I know a lot of individuals walk in and present it as that way. But we monitor and report on the stats every single month how many patients are referred to emergency department. So that in actual fact, for 70% of individuals who tell us at the beginning of the call that they were going to go to the emergency room, we redirect away from the emergency department, to the point that in actual fact only 12% end up referred to the emergency departments. Now that looks at, and I'd be the first to say that looks great on paper, and these stats are great and so on, and they are. However, we all know there's so many limitations to accessing follow-up care when need be. So if we talk to a patient on a Friday evening who's got a urinary tract infection, and we tell them what to do to get through the night, or with strep throat, and we say, talk to your doctor tomorrow or on Monday, or whatever the case may be, and they don't have a doctor to go to on Monday, or they're unable to access an appointment and so on. These are the individuals who often are walking in to the emergency departments because they've got no other access. So a big piece of what we're trying to do in all of our conversations with the province is, how do we manage that care better than we're doing today? How do we make sure that that coordinated care and the handoff to care is available and so on? And that's not just a problem specific to Newfoundland and Labrador. That's everywhere in each of our operations, in every province, in every country. Everybody is trying to figure out those pieces. But these are the actual referral numbers and what they look like today. So just to give you a snapshot of the types of calls that we receive on a monthly basis, I just got to, you'll see on the screen there, the top 20 type of calls that we receive today. In adults, it can move anywhere from, chest pain to coughs to urinary pain, and right all the way down to, erratic heartbeat or a fast heartbeat or whatever the case may be. And then everything in between. We receive quite a few calls related to mental health conditions, depression, and so on. Some of these calls are very difficult to manage, but again, it's providing the very best access to care and managing risks as best we can. And then on the pediatric side, the most common ones are coughs, colds, just exactly what you'd see if you were working in an emergency department, who typically would walking through lots of babies who falls off change tables and so on. These are the typical type of calls that come in and every single month. So our nurses will basically triage the presenting symptoms, come up with a path for care. We do have best practice clinical protocols built into our platform to help guide the nurse's decision and guide her nurse's assessment and certain questions to ask and so on. But at the end of the day, the nurse is responsible for managing the symptomatic presentation of the call and applying her clinical knowledge and her critical thinking skills and coming up with a pathway forward for care. So that's a typical type of calls that we receive. As I said, prior to the pandemic, many people didn't even know we existed. And then all of a sudden we became so popular that it became very overwhelming for us, as you can well imagine. And I've just popped up here on the screen just so you can see the difference in the call volume from 2019 to 2022 alone. And just significant bump in calls from 47,000 a year to well in excess of 200,000 calls in 2022. And on a monthly basis here in Newfoundland, Labrador alone, we manage upwards of about 20,000 calls every month just here from the province alone, either nurse advice-based calls or escalation to nurse practitioners and so on. So the volume has significantly increased in the province. And to manage that, it takes a team that's dedicated, no doubt about it, but it really does take a community working together to enable us to be able to manage that volume. When it comes to practicing, much the same as any registered nurse who practices within the province today, when it comes to licensure, graduation, academic background, and so on, either registered nurses or nurse practitioners and so on, what's required to be able to practice, working for FOMED as a registered nurse or nurse practitioner and so on. And typically we look for a minimum of 2 years. Most of our nurses who work with us today have an average of 10 to 12 years experience working as a frontline nurse, but the minimum we accept is 2. And I think many times when people come to work at FOMED, they think, oh, this is a great job because it's really easy. Somebody got a headache, you tell them to take a Tylenol and call back in the morning and so on. But it's very, very different when you learn to triage with your ears versus your eyes and learn to make decisions that nobody else is going to walk in the room once you leave. So you need to make sure that the clinical assessment that happens during that call is an assessment where that patient is in a good place and that you've addressed all the risks involved in whatever the presenting situation is and so on, and left the patient with enough knowledge to be able to manage their care going forward. And, with the advice for at what point they should be seeing an improvement, and if they're not, when to call back and so on. So considering all of the risks involved in making independent decisions, critical thinking skills is what's most important for any triage nurse. Prior to the pandemic, almost all of our nurses and intake agents worked in-house in one of our health contact centers in Corner Brook, Stephenville, or St. Anthony. And it's only since the pandemic that everybody went to work from home. So we've got nurses, agents, and nurse practitioners living and working from every nook and cranny in Newfoundland and Labrador today. And we've brought on a phenomenal team over many years, but especially since the pandemic. It's just been amazing, the outreach we've had. And, we all are very acutely aware of the shortage of healthcare workers in the province today. And what's worked best for us is offering multiple different part-time positions, so that it allows individuals to maintain their frontline practice, and whether they want to pick up some extra hours on the weekends or after hours during the day, had a lot of retiree nurses and nurse practitioners who had come to work with us over the pandemic and so on. So it works very, very well for many people. And again, the technology is really important because for nurses and nurse practitioners and agents who work for us, they must have a high-speed internet connection, because in order to get all of the security features and that in the back end of all of the work that we do, the security architecture requires a high-speed internet connection. So that's the minimum requirement for anybody to work from any nook or cranny within the province today, and then a whole bunch of other skill sets that we evaluate for and so on. So that's, we've been very fortunate in that we've been able to recruit, as I said, a phenomenal team that I'm very proud to represent at FOAMed. Our approach has always been to be a community partner. And it's only by being a partner in the community, being a partner with the province and with the clinical teams that we work with in the province today, and our partners in the province who we collaborate with to provide continuity of care and so on, that this has actually worked. And our approach has always been a collaborative approach. It's not ever in any way, shape, or form to try to replace the public system, which I too, being a Newfoundlander, hold very near and dear to my heart, but to work with the partners in the community to make sure that the work we're doing is supportive of the work all you great people are doing on the front line. So that really is the intent of what we've done. That's how we've built the operation from day one. And that's certainly our intent going forward, is to be a partner with all of you who are on the front lines, who are making the difference in the province today. So thanks so much. I appreciate everybody taking time to listen. And that's a little bit about our organization. So I guess, Peggy, I'll turn it back to you.
Hi, it's Wanda, actually. That's all right. All good. I'm going to step in here for a second.
Back to you.
All right, thanks. So thank you so much, Charlene, for providing this education. And we have all seen such a wonderful job that FOAMed has certainly done over the last couple of years and in previous years, but we've all seen the increase since COVID. So, it's really helped out Newfoundlanders and Labradorians quite a bit. So I want to thank you all for your services at FOAMed. So with that said, we are going to pass it back now to Annette and Peggy, and we'll look at some questions and answers and closing remarks.
Yes, thank you. Thank you, everyone. What wonderful panel presentation, such great information and such reflective things to keep thinking about and asking ourselves as we integrate or use virtual care in our practices. So thank you, everyone. So we have lots of time for some questions. And if you haven't gotten your question in yet, feel free to send it along. We do have some time there for questions. So one of the, just more of a housekeeping question that we got was around the slides and if they would be available. So they were loaded onto the webinar platform. And so if you aren't seeing those, you can just refresh your page and you should be able to find those slides in the resource widget on the webinar platform. So getting into some of the questions, and maybe Stephanie, this one might be more directed to you, but others can jump in. But we'll start with you, Stephanie. In terms of what would you do if you were worried about a client's safety during a virtual appointment, and other things that healthcare professionals should consider if they're worried about a client's safety?
That's a great question. So that almost comes back to, I feel like, the very beginning stages of our work together. So again, we would kind of, I guess any session that we have would be no different than in our office. So when we meet with a client for the first time, we would be going through things like informed consent and confidentiality. And if a person, wasn't feeling safe, what would some of those options be? So who would we want to contact? Is there like a parent number? That kind of thing. So having those emergency contacts, I guess, readily available would be helpful. Knock on wood, that hasn't happened yet. I shouldn't say that, but it hasn't happened to me yet. But I guess in the event that it does, that's what we've all consulted and discussed, that we would make sure that we have all that information up front, and periodically maybe like just reviewing it to make sure that that person's emergency contact information is ready to go, and we know who to reach, and whether it's their number or an email address, making sure that parents are aware of emergency resources as well. If they need to go to the emergency room, for example, or connect with, a physician or some other support person in the child's life. So that's one of the things. That's probably one way I would answer that question, I think.
Mhm. That's great. Thank you, Stephanie. Did anyone else want to jump in on that question? Additional comments?
I think I could just add as well, as you can well imagine, through 811, we manage quite a few of those calls as well. And every decision we make is based on the risk assessment. So at the end of the day, patient safety trumps everything else that we do. And sometimes you make some calls or, have to reach out to community partners or resources to make sure that that individual is okay. And because, we all need to make sure that when we go to bed at night, we can lay our head down knowing that we did everything we did to make sure that the patient was in a safe, secure place. And, that comes with time and experience and how you manage them and so on. And so what, it's thought about, it's talked about, just like with Stephanie's organization with ours every single day as well.
Okay, thank you. Thank you, Stephanie and Charlene. We had I'm going to combine the next two questions because Charlene, as you were speaking about, the staff that you have with the RNs and the, dietitian as well, there was a question wondering if there was going to be a plan or any thought to integrating social work and LPNs within PhoneMed.
Yeah, there certainly is. And now more than ever, over the last 2 years, the conversation every single day is what's next and what else do we do and so on. And all of our business has been built listening to the needs in the communities, no matter which country or province we're in or whatever the case may be. And I think what we're all recognizing is that mental health population is a population that is really, the needs have really not been fully addressed today. One of the pieces we're looking at under programs is a managed care program to manage individuals with access to healthcare records and so on, because episodic care is only as great as episodic care can be. It's providing that longitudinal care that's going to make the difference in the lives of individuals in our province today. So looking at adding social workers and LPNs and various other disciplines is absolutely on the roadmap for us and in the very near future as well.
Thank you, Charlene. Peggy, did you have any questions you wanted to?
Yeah, so I have a couple comments that I could put together. So there was a comment there about how lots of times in rural health and on the Northern Peninsula and primary care that they've tried video and there's not good enough Wi-Fi. And sometimes the older population don't have internet access or that technological savvy. And I think, Charlene, you spoke about that and how a lot of technological issues have to be worked out and that you can still do stuff by phone. So I don't know if anybody wants to comment on that risk.
I think for everybody, anytime you get an opportunity to have a voice with the province over the importance of expanding that connectivity piece, and every time I get an opportunity, I look for it because that's really important. And, we can do so much over the phone, but we can do so much more with a video capability and so on. So I think it's every single Newfoundlander and Labradoran being a champion for expansion of the connectivity here in the province is going to make a difference.
Yeah, and I can certainly build on that because with when there is challenges with Wi-Fi within the home or the proper technology, that's where our facility base does come in handy within the health authorities, especially. And we've looked at partnering with different community-based areas where, there might be a suitable device in the library. We certainly can work with any clinical group to, help navigate some of those challenges to bring a client into the nearest facility where there's technology. And we've also done device loaner programs. So if it's a client that you're going to be seeing for the next 8 weeks and it's, kind of a certain amount of time that you plan to see them, we can deploy Wi-Fi enabled iPads. So some clinical programs purchase them and we'll work with them to find the right tool so they'd actually use cellular for the appointment. So there's different use cases that we certainly will try to work through to get the access as best as possible.
Thanks, Ash. I have another comment there just about how virtual video consults through Jabber are very helpful, and that they've been able to email pictures and consult with other healthcare providers using virtual means. And then there was a question about, can private practitioners access virtual platforms as well?
So within the virtual care program, the allotted funding that we have mostly supports the regional health authorities. There have been times where we have supported private clinics for the physician groups. But to date, we haven't been able to support other private clinicians within our program. And we're certainly, as we expand and as we, adapt to the health accord, we do expect, there'll be different opportunities coming, but we will work with any clinical group to help pick the best tool. So we have worked with private clinics in, testing different solutions and making recommendations to them. So it might not necessarily be the license model that we have within the Center for Health Information, but we could, describe the right Zoom for Healthcare account or WebEx account that would be appropriate. And then we can share, the different privacy and security risks and different mitigations that we put in place today.
Excellent. Annette, do you want to do number 12?
Yes. So another question that's come in is, if you have a client that you fear or believe is anxious or uncomfortable with, leaving their video on. So if you're doing video conferencing and a client is, uncomfortable with having their video, what are some things that you might consider there?
I've had some, experience with this one. So lots of times, if young adults are coming to us and anxiety is the primary reason, for whatever reason, they may not be able to get here physically for in-person sessions, so they would opt to try virtual. And part of in the informed consent process, part of the Eastern Health Standards as well, for virtual care is to have your video on. So we would go through those guidelines. And if this is something that a parent addresses or a young person addresses, we basically just state that, we'll certainly work together with you to do that. So it can be something, for an example, as maybe for the first session, you can turn your camera on, but it wouldn't necessarily be your whole face visible, for example, if a person wasn't comfortable. Perhaps it could be tilted to the side or tilted up at the ceiling. And then part of our treatment plan could be, we're going to actually use some approach behaviors and give you some skills and eventually start building up. And over a series of sessions, we might actually, work up to doing that. I'm doing that right now, with a young person online. So there's definitely ways that I think we can be creative. I don't think a simple no would be the answer necessarily, but it would be, let's work together to figure out how we can make this work.
Thank you. Did anyone else have any thoughts or comments on that question?
And I would probably say the same, and that happens with us many times as well. We were also excited, jumping up and down, when we finally enabled our video connectivity piece and so on. And then we were also deflated when we found out nobody wanted to use it. So even though today we offer the video assessment piece, the majority of individuals choose telephony only route. And in the mental health world, for us in particular, many individuals, would like to remain that way. They almost feel anonymous some way by not turning on their video camera. And we leave that entirely up to the individual. As I said, any care is better than no care. So if there's any help we can provide, whether with the camera, it just allows you, of course, Stephanie would know better than anybody, to assess, facial expressions and movements and so on, to determine anxiety levels and so on. But a lot of that you'll pick up over the phone as well. So we leave it in the hands of the individual. I mean, for some cases with the nurse practitioner, if you got to look at a rash, you got to look at a rash, so some cases it's, we really would encourage it. But again, we leave it up to the individuals for the most part.
Wonderful. Thank you. This is a question, maybe Elise will throw this one out to you in terms of, professional practice. And you noted at your beginning of your presentation how we're held to the same, standard of care. So just around some suggestions for how to avoid, professional practice complaints or issues when using virtual care.
Yeah, sure, Annette. A lot of the complaints that we've been getting are about communication. And I think that sometimes it's harder to build that rapport virtually versus in person. So I think when you are providing virtual care, I would pay extra close attention to how the information is being transmitted and received. And are you still building that type of rapport with the patient? Because oftentimes, if the patient doesn't understand something, that might result in them complaining about the care that you've provided. But if you can really get through to them, you won't end up in that situation. So I think really that communication, building that good rapport with the patient, making sure that they understand the information that you're providing, giving them the opportunity to ask questions, not making it feel like it's rushed. And that you're just sort of giving them a real cursory review of their circumstances. And I think also just to remember that virtual care is sort of viewed as the same as in-person care. So do the things that you would do in person, even though you're providing the care virtually. So in the back of your mind, go through the list of whatever is appropriate for your discipline and make sure you're checking off all of those boxes.
That's great. Thank you, Elise. Hey, Peggy, are you seeing any more questions there from your end?
There's lots of really positive comments about, to our panelists about the panelists' efforts to support, access to healthcare in the province. We have the one about risk. We asked about that. Is there any statistics on professional practice complaints specific to virtual care, or any themes or trend or issues from social workers or nurses that you can share or keep in mind or to help to reduce risk? It was just communications.
Yeah, I think that's what, Elise, you would have just addressed.
Yeah, and I'm speaking from the physician point of view because that's where my practice is. I think we get the greatest volume of complaints of all the regulators, and I would say that we don't really have enough data to be giving a lot of information that I think is really informative at this stage, because virtual care has only really been a big player in the care providing for the past couple of years. So I think in the next few years, we'll start to see some more trends, but I'm definitely seeing that many of our trends relate to communication and how the information is sort of disseminated between the patient and the provider.
Mm-hmm. Okay. Thank you. We had another question around, can you please provide further information about the virtual ER since it was placed strategically all over NL on the map that you showed in the slide? I guess that's for you, Ashley. And how can patients avail of the virtual ER?
Yeah, so the virtual ERs is in response to human resource challenges across the Category B facilities. So the stars would have been placed over most of the Category B facilities, as most of them have gone live or have been trained to go live with a virtual ER. So if a Category B site does not have the physician coverage for a certain period of time, they have the opportunity to switch to a virtual ER. So there will be clinical staff on site, and the RHAs will send out memos, and they do different ways to post within the community to let them know what is available. So if their local Category B facility is on virtual ER, then there is no physician on site, and there's nursing staff, there could be advanced care paramedics, and a variety of other staff, respiratory therapy for airway management and those things, and they would actually see the physician virtually. So it's not necessarily that all 12 are live at any time. It could be that one is only live on a weekend, or it might just be one day, or between a certain period of time actually when the physician is required to have rest. So they might be at the end of a 48-hour shift and they require so much time off, so they will revert to virtual, depending on whatever scenario it is for those physicians. So that's when we use the virtual ER scenarios.
Perfect, thank you. Another question that we had is there any different kind of consent required when doing virtual care versus in-person care? Anything extra that we need to consider around virtual care?
From the virtual care program, consent is implied when the patient accepts the appointment and joins the virtual, especially the video conferencing appointment. But it depends on the actual program area and the requirements within their professional practice. So some groups do require consent. Some require consent prior to the appointment even being scheduled. So it really depends on the actual program area, but within our program, it is implied when the provider accepts or the patient accepts, sorry.
And I think the only thing I'd add on to that is that if there's a limitation of the virtual care, so if there's something that you're not able to do because you're providing virtual care, I think it's important to make that clear to the patient. Like, if I was with you in person, I would also do the following, and I'm not able to do that because we're virtual, so that the patient understands as part of the consent process that they might be missing something because they're attending virtually. So that's sort of the informed consent is understanding any limitations of the virtual appointment.
And it's important to let the patient know too that they can end the appointment at any time and revoke their consent, even if it was implied. They can decide to end the appointment if they felt that they're better suited to be seen in person.
Yeah. And I think, Stephanie, I'm reminded about some of the things you said in your presentation, even around what some of the, and Elise, you just mentioned at the limitations. So I'm thinking, like, even if the power goes out and you lose connection with the client, like, how are those kinds of situations going to be addressed, and is there an alternate way to connect? So some of the things you were talking about really resonated around some of that informed consent discussion as well.
We have a couple more questions there, Annette.
Okay, did you want to pull one out there?
Yeah, sure. So where are we with sharing information between various virtual providers like PhoneMed and the GP offices?
I can speak to it kind of generally. It's not fully my area, but HealthyNL would be the kind of the most accessible piece across the province to be able to share information. A number of providers are on the TELUS Med Access platform, so there is opportunities there as well. And yeah, so I would probably say HealthyNL is the most accessible piece, and I know that PhoneMed has been involved in getting access to HealthyNL, and GPs would have access as well, and other private clinicians.
Right. And we're very much working with the province and taking it even a step further. And I apologize, I lost my connection for a second there, so I think I froze. And we absolutely are working with the province and taking that even a step further as well. And again, it's back to my earlier comment about the longitudinal care, and the more we can share and the more we can communicate with each other in the community, that's again what's going to make a difference, and so on. So that conversation is absolutely underway.
Okay, thank you. And I know many of our presenters, you touched on this around cross-border care. But again, the question is around, so if you have a healthcare provider who's, licensed to practice here in Newfoundland, Labrador, and you have transitional workers, so workers who maybe on rotation, going outside the province in terms of that continuity of care piece, are there any jurisdictional limitations for the use of virtual care? And does this vary? And what should providers know to ensure that they are practicing safely in these situations?
I think the answer is it's complicated.
I think so too.
I wish it was less complicated. I could speak to physicians, but there's different rules in different provinces, and they don't align. And so I think as a practitioner, the best thing to do is if your patient's located outside this province, to look at where they're located and look at your regulatory body in that province and determine whether or not any action is required. So do you need, a virtual care license? Do you need a full license, or are you okay to proceed? It's not straightforward from what I can tell.
And that's very similar to social work. What we have in place is to say that you have to be aware of what the jurisdictional, regulatory requirements are in the jurisdiction where the client is. So if you're in Newfoundland and your client is, working in Alberta, then checking with the Alberta College to see what regulatory requirements had to be met prior to engaging in that service delivery. And that's in our standards of practice and in some of our practice resources. So we have that outlined for our members as well. And I'll let Peggy and Wanda speak to it from a nursing perspective.
So I'll go first, Peggy. Is that okay? Great. So for a licensed practical nurse, yeah, it's the same thing. So you'd have to be licensed in the province in which you are currently situated or you're living, where you're practicing. And we tell licensed practical nurses that they must reach out to the jurisdiction in which where the client is physically located, as they may have different requirements. But if you're living in Newfoundland, then you must have a license to practice in Newfoundland for carrying out any types of care.
And we are very similar. And we do have a slide on some resources that all three of the colleges have available. And one of our resources that we have listed is on licensure requirements. But again, it's the same. It's where you are physically located. So you're licensed where you're sitting. And you do have to reach out to the other jurisdictions to ensure that you can meet their practice requirements, or if there is any other licensure requirements that need to be required. And we also say that, and it goes with everybody's presentation about, is this the best method? Because if, you have to be, your patient on the other end has to be able to carry out your instructions. So it's really important that, that you're aware of what you can and cannot do where your patient is physically located. So it's, so that they can, access their healthcare in a timely manner.
There's a nice comment there. I just wanted to say to everybody, the comments, thank you to all the presenters for this outstanding presentation. I was very skeptical about virtual care and knew very little about it. Your presentations have educated and encouraged me. Bravo to all of you for the work that you do to provide healthcare in Newfoundland and Labrador at these very challenging times.
A nice little summary there from one of the participants in today's webinar. Yeah. So I guess we can maybe just open it up now to some concluding comments from each of our presenters today. Maybe something sparked in a question that was asked, or maybe something that, your fellow panelists might have said. So we'll just take a couple minutes and maybe if we just want to go around and provide some concluding thoughts and comments from each of the panelists, that would be great. I'm not sure who wants to start or if I'll pick someone, but
I can start, Annette. Oh,
okay,
go ahead, Charlene.
Lisa or Charlene?
I guess I'd just like to say, thank you guys again for the opportunity to have a voice. I think we all here, for us in the private system especially, there's been lots of challenging times, as you can well imagine, in the last couple of months as the awareness came of private company and the public system and so on. And I think, for the most part, what we all do is we just keep our heads down and do the work that needs to be done. But, I think it's because of all of you folks that are doing the great frontline work that we've been able to support you in the way we have. So I know how challenging it is for you all going to work day in, day out, and the challenges that you're experiencing on the front line. So just thank you for all of the work you're doing. We'd never be able to survive as a province or as a country without you. So just thanks for allowing us to support you the best we can.
Okay, Elise, did you want to go next?
Yeah, I think, from my perspective, which is the risk and the, don't get in trouble type of perspective, is always consider the best interest of the patient. And I think all of you likely have that at heart, but when you're thinking about your patient and their best interest, it's likely that you're on the right path and you're thinking about the right things that you need to be concerned about. So in the back of your mind, what's best for my patient, I think is important.
Wonderful. Stephanie or Ashley?
Sure.
Yeah.
I can go. I just wanted to thank everybody for their time and their information. I certainly learned a lot myself going throughout this process. And I think, flexibility is key. And I guess, especially working with the adolescent population, but any population, just being able to pivot and having that hybrid model. And at the end of the day, client care is why we're all doing this. So, yeah, so thanks again.
Thank
I
you.
guess where I start, I'll end it off. But if our team, so we are regionally spread, we're spread out across all the regions. So if there is any questions about virtual care and you're considering it or looking to enhance the service that you might already do, so you might use phone and want to incorporate video, or looking at the peripheral devices, we can certainly go over the tools and solutions that we have and help you expand, whether you're in the health authorities or in private practice. The provincial program is here to be able to support you. So you can certainly reach out at any time.
Excellent. Thank you so much, Ashley. So we'll just quickly share the resources that we put together from the colleges here this afternoon in terms of what you might want to access. And all the documents are available on our respective websites, and we put our website addresses there as well. So, for example, and I could speak to the first slide around social work and some of the materials that's available through the college. We have, an interjurisdictional. We had a lot of questions here today around interjurisdictional practice. So we have an interjurisdictional social practice FAQ and practice guideline document that we encourage, people who are thinking about or engaging in cross-border practice to have a look at. We have an explanatory document on technology use in social practice, so how we use technology in our work, including for e-service or virtual care. Some information around virtual care, key considerations. What things should I consider pertaining to documentation? At least you talked about the importance of documentation in your presentation. And from a social work perspective, what are some of those key things that need to be thought about? Some resources around electronic social work practice, and of course, our standards of practice that does address, care and interjurisdictional practice, and whether that care is virtual, in province, virtual, or face to face. The same standards apply. So I can transition next to Peggy, and maybe you want to give a quick overview of some of your resources.
Yeah, so along with our standards practice and code of ethics, we have some specific resources to virtual nursing practice. The first one is our virtual nursing practice document, and it's a set of guidelines, and it really combines what everybody talked about here today, where there's an appropriate duty of care, appropriate technology, and appropriate resources. So you could look at that document. We have the licensure requirement document. It's a fact sheet on the licensure requirements, and it goes through cross-jurisdictional licensures and being licensed where you sit. So if you are physically located in Newfoundland, and despite where else you hold licenses, if you're physically located here, you need to have a practicing license where you are physically located. And we also have some archived education sessions on virtual nursing practice. So that will bring you through the appropriate use of technology and duty of care and so on and so forth. And I got the links to the website there, so you can take that from the resources.
Thanks. And from a College of Licensed Practical Nurses perspective, we have several documents also on our website, clpnnl.ca. We do have a fact sheet on licensure requirements for LPNs providing virtual care services that we spoke greatly about earlier regarding where you sit and, clients in other provinces and so on. We have a new social media networking platform statement that we just released back in December on an LPN's responsibilities and accountabilities when it comes to the use of social media and different networking platforms. We also have collaborative document that we did with the College of Registered Nurses on documentation practice guidelines, and how important it is to take the time to document and what that documentation looks like, whether it's virtual or in person. And we also have a position statement on privacy. And not to lose attention to our standards of practice, of course, and our code of ethics, which is also found on the CLP&NL website. All of our document library is found under policy and practice under the CLP&NL website. So thank you.
All right, so lots of resources. So great discussion today, and lots of resources that people can tap into later on. But I guess just to wrap up, I want to say a sincere thank you to Ashley, Elise, Stephanie, and Charlene for a great presentation, great panel presentation. Such diverse perspectives. We're all coming at it from different pieces, but it all certainly collectively is such great and important information, and I really appreciate the perspectives that everyone shared, the information. There's so much for us to be thinking about and reflecting on, and more discussions that are going to happen within our teams, with our colleagues. So it really truly was an opportunity to reflect on the ethical and practice considerations as it relates to virtual care, and an opportunity for knowledge exchange, reflection, and learning. And I think the session really highlighted some really important things that we need to be thinking about in our practices. So again, thank you so much to you for joining us today. And to assist with our planning for next year, there should be an evaluation form that will come up on your screen as you leave the webinar. So we'd love to hear your feedback and thoughts and perspectives on that. Some suggestions for a topic for next year even. Social workers attending this session may claim 2 CPE credits under their workshop category as per the NLCSW continuing professional education policy. And I'll let Peggy and Wanda talk about it from their perspective around CE.
So as you know, we have the My CCP portal under My CRNNL, and you can absolutely put this session in and claim your number of hours, your 2 hours.
And for licensed practical nurses, you can use today's session for 2 hours towards your CCP, but be sure to log it on the Record of Learning Activities form, as all education would get logged on that form. And those forms are found under CCP on the CLP&NL website also.
Wonderful. All right, well, thank you everyone for joining us. I can't believe how fast 2 hours went, and really appreciate the large number of registrants that we had for this session. We hope you take lots of information away, and if anyone has any questions from a college perspective, feel free to reach out to us, and check out our website with all the great information that will be there as well. And the recording of this presentation will go up on the websites of our colleges as well. So if you want to re-listen to something, or a colleague that wasn't able to attend today, we will have the presentations available. So thank you, everyone.
Thanks, guys.
Thank you.